Proptosis, paranasal sinus, frontal sinus, downward and lateral displacement like frontal mucocele and all, osteoma, frontal mucocele and osteoma, or any other frontal sinus malignancy and all, which is occupying completely frontal sinus and pushing onto the medial side of the orbit, which pushes the orbit to that of the lateral side. That's the one way. The other thing is paranasal sinus, ethmoid sinus. Ethmoid sinuses both are present both orbital this thing. So when there is a ethmoid sinus occupying pathology, obviously like any pathology like this, I have mentioned mucosal and osteoma, fungal sinusitis and malignant tumors and all will push the orbit towards laterally. That's how you determine towards the ethmoidal malignancy or ethmoidal sinus pathology. That's it towards laterally. Then comes to that of the maxillary sinus, which pushes the orbit superiorly, any maxillary sinus pathology. So that's one cause for change of direction. So when it comes to lacrimal gland, which is present superiorly, superior-laterally of the orbit, which pushes the orbit inferior-medially. That's how it was this thing. Oh, this is for maxillary sinus. Then comes proptosis of the orbital lesions like hematoma, cellulitis, abscess, malignant tumors in situ or not in situ, in the orbit itself, behind the orbital structure. It leads to pushing of the orbit more anteriorly, which is the one most common cause, which we don't deal much by any ENT surgeons, which was dealt more by ophthalmic ophthalmologists. Then comes to the next symptom, sneezing, paroxysms, like episodes of sneezing. Number of sneezes per attack is also important. Any specific precipitating factor, exposure to allergen or any other thing, which gives rise to towards allergic this thing. The number of sneezes, the sneezes are more violent, and number of sneezes are more like 20-30 sneezes, which goes towards that of the allergic rhinosinusitis. Of course, sneezes associated with something like sneezes associated with what is that, itching and all, watering of the eyes and burning sensations in the nose and nasopharynx and ears, more of towards allergic rhinitis. This is one kind of symptom. When we are dealing with each and individual disease of the nose, we'll be dealing more with that of the particular complaints. And post-nasal discharge. This is one big characteristic feature of post-nasal discharge is the one characteristic feature of constant discharge from somewhere, excessive discharge, or constant decrease in mucociliary transportation mechanism, which is mostly in combination. Both are due to chronic sinusitis, obviously. Hawking. Patients tries to clear off the nasal cavity and the nasopharynx. That kind of sound, that is hawking, which is usually the most common precipitating factor from the symptom from the patient. While we are talking to that particular individual in the OP itself, we can that thing, especially these post-nasal discharge patients, cough with or without expectoration will be there when they are awake, as the thing comes out through the post-nasal or sometimes you may have a large amount of expectation, not. Patient very seriously. Change of voice once again. Rhinolaryngeclasia, these are the two particular changes of the voice. Rhinolaryngeclasia and aperta. Clausa means closure of the nasal cavity, especially in the nasopharynx. Aperta means opening of the nose into the oral cavity. This is the thing. So various reasons and causes which are there for the clausa, like simple nasal obstruction by means of adenoids, or by means of any mass presenting in the nasopharyngeal lesion, that is nasopharyngeal obstruction. Most commonly causes loss of nasal intonation, that nasal resonance is lost because of the nasopharyngeal resonance is lost because of the obstruction, that air flow will not be there through the nasal cavity into the nasopharynx to outside. So that different type of voice will be coming out. That is what is called rhinolalia clausa. And rhinolalia aperta, when the nasal cavity is completely exposed to the oral cavity, like cleft palate and cleft lips and all. Not in cleft lip, much of more of cleft palate. Any cause that nasal cavity opens into the oral cavity, losses of this thing, rhinolalia aperta. These are the two change of voice situations. And change of voice. These are the two change of voice situations. Then comes to the external nasal deformity, congenital, acquired, and history of trauma, specific infections, and malignancies. Even benign tumors also can cause some of the changes in the nasal cavity, congenital, bifid nose and bifid this thing and all, acquired due to injuries and all, history of trauma. Due to trauma, there is a change of the nasal pyramid shape and size and all maybe there. Specific infections, syphilis and all causes septal destructions, midline granulomatous disease in the nasal cavity causes septal destruction, may change the nasal cavity and nasal pyramid shape also. And of course, malignancy, as usual, you have a local destruction or Telangana, and benign tumors or benign infectious lesions like rhinophyma and all, like our KCR Telangana minister's nose. We have some amount of deformities in the nose, and even simple furunclosis and all also can cause the deformities in the nose, but they're all temporary. So now comes to the main important thing. These are the above points till now we have discussed is some amount of the nasal symptomatology. In gross, you come into contact with the patient, but each and every disease predominates with one kind of symptoms more and one kind of, other kind of symptoms will be less. So we have to discuss those things when we are particularly discussing that particular part of the particular disease. So particular symptoms will be more highlighted in that particular when we are discussing about that particular disease. So now let us go on to that of the examination of the nose. Examination of the nose, tinkle examination of the nose. So we need what? Good light, headlight, reflected light from the head mirror. So these are so many things are needed. In the olden days, we used to have bullseye lamp and head mirror. Nowadays, we are having headlights straight away, and nowadays we are getting a laser lights and endoscopes and halogen lamps, halogen fiber, good fiber cables, and also now the inspection part of the nose and nasal cavity is more illuminated, more close-up look is being seen. And we studied post-graduation, used to have a headlamp only. Now we are equipped with good light sources, xenon light sources with endoscopes and all. So the examination is more easy and more informative and more diagnosis wise we can do a quick good perfect diagnosis with the aid of this kind of good things. The examination pattern is totally say changed. Suppose, for example, we used to have a posterior rhinoscopy we used to do by putting a mirror in the oral cavity, asking the patient to breathe with the mouth and all nonsense. Now we don't have all that. We don't need all that. Just put an endoscope in the nasal cavity. We can just simply see the whole nose from nasopharynx to entry end of the nose. So inspection and palpation, look at the skin inspection. When you inspect the nasal cavity, you look at the pyramidal shape of the nasal cavity and alar flare, loose ala ఏమన్నా ఉన్నాయా లేవో చూసుకోవాలి. Like means if when you are breathing through the nasal cavity, ala will be collapsing in the loose and the ala shape also you should see. And when you see, look at the nasal cavity or the pyramids of the nose, any scars or any diseases, any furuncles also you should see, and you should have to assess the shape. Look at the vestibules, that is what is called on elevation of the tip of the nose, like this, on elevation of the tip of the nose, so that you can see the only vestibular skin part of the nasal cavity. Why this is so important is, suppose for example, if you have a vestibule furunclosis in the vestibule or chronic vestibulitis, which is a very painful condition, you suppose instead of not seeing with the lifting of tip, without examining the tip of the vestibule of the nose, suppose if you insert a pseudocum speculum directly for anterior rhinoscopy, suppose there is a furuncle which may burst away. As you know, all this particular area is the dangerous area of the face, which may directly spread the infection directly to the cavernous sinus and all. So palpating for sinus tenderness and all. These are comes into both in inspection and palpation. Palpation is not only for sinus tenderness. The nose pyramid is must be palpated when there is a injury to the nose to feel the cryptus of the nasal bones. And when you see that the chronic infection of the vestibulitis, suppose for example in allergic rhinitis, there is a thickening of the cartilage in the ala. So likewise with a palpation, you can assess the shape of the nose and you can see the cryptus of the nose. You can see the injuries to the nose with a palpation. You can exactly assess the inspectory, exactly confirm the inspectory findings of the nose. So these things can be seen and done. Next comes and another thing, very important thing is occlude the each nostril and assess the air entry into by means of cotton, putting a cotton or tongue dipser. That is how you assess the function of the. I think this is not the next slide. It's good light and all. This is, yeah, this is only Cotle's test. Cotle's test is pulling up the cheek towards one side, uh, putting a putting the hand like this on the cheek and pulling the skin of the face towards one side so that particular nasal valve region obstruction is being confirmed on that particular side. The nasal valve is the region where the skin of the external skin of the vestibule finishes off and real mucosa is started off. I think you know the Cottle's line and Cottle's nasal vestibule both differs. Nasal vestibule is the inner opening of the and nasal cavity, which is the narrowest part of the nasal cavity. This particular part is anterior nasal anterior naris. The posterior opening is choana. In between that one part is called narrowest part. That is exactly the lower lateral cartilage of the pyramid, where it is ends and combines with that of the upper lateral cartilage, alar cartilage. That particular region corresponding to the inside of the nasal cavity is the nasal valve region. If there is a obstruction at that particular region, nasal valve region, you can do the Cotle's test and you can confirm it. That is a there is a obstruction over there. This is what is called Cotle's test. I think it is given in the books. You can read well. If you pull the cheek like this and it opens up, that means the region of obstruction is exactly at the level of the nasal valve region. Nasal valve region. So next comes the anterior rhinoscopy. Anterior rhinoscopy is to visualize the nasal cavity from the anterior end of the nose by means of using a Tudicum's nasal speculum. So before doing anterior rhinoscopy, one must do that elevation of the nose. Elevation of the nose by means of a finger. I have told you this regarding why means there is some pathology, some inflammatory pathology or abscess like pathology may be there in the vestibule of the nose because the vestibule of the nose is containing the region of normal skin where there is a multiple number of hair cells are there, hair are there. So whenever there is a hair, the hair follicle infection might lead to some amount of abscess or furunclosis, which is a very painful condition, which if it bursts on its own or by means of any this thing, it might spread the infection, might spread this thing. So anti-rhinoscopy, how do you do anti-rhinoscopy? You hold the tuticum speculum and you try to spread the, we try to open up the nose to a little extent. You are not supposed to keep the tuticum speculum to completely expand so that it gives pain on the vestibule or to certain extent until you get a good visualization. You have to open it and see that contents of the nasal cavity. Usually on rhinoscopy, you can see inferior turbinate, mucosa of the floor of the nasal cavity, mucosa on the lateral wall of the nasal cavity, nasal septum to some extent, at least anterior and up to 3/4 of the nasal septum you can be seen, and glimpse of the middle turbinate can be seen. If the nasal cavity is wide, you can see that of the posterior end of the nasal cavity also, but in Indians and African noses, you can see that, but whereas in European noses, you cannot completely see the nasal cavity by means of doing a anti-rhinoscopy. Once you try to take out the tuticum speculum, you don't try to close the Tutkam speculum completely, uh, approximate the completely Tutkam speculum blades so that you will be catching the hair in the nose and you will be pulling it and you will be pulling it. So I don't want you to do that. You are not supposed to expand completely Tudgum's nasal speculum blades, and you are not supposed to completely close the Tudgum speculum blades while you are removing the Tudgum speculum. So that's how you have to do. These two are very important. If you open it to completely, it will give you pain. If you completely close it, you may pull the hair also. It will also give rise to some pain. So that is the technique of doing anti-rhinoscopy. Post-rhinoscopy. So post-rhinoscopy is to visualize the post-wall of the compartment of the nasal cavity, that is nasopharynx, and visualizing the nose from the posterior part of the nose. So that's this can be done by means of asking the patient to open the mouth. You take a mirror, Saint Clair Thompson's posterior rhinoscopy mirror. That is, you read in your books that even it will be having a bend. It is different from that of the indirect laryngoscopy mirror. Saint Clair Thompson's indirect laryngoscopy mirror. I mean, posterior rhinoscopy mirror. So through which you can ask the patient to open the mouth and depress the tongue and ask the patient to breathe through the nose. If he breathes through the nose, the palate will come down so that you can put the mirror behind the palate so that you can see that of the all contents in the nasopharynx. That is posterior end of the septum, posterior end of the inferior and middle turbinate, and laterally you can see the eustachian cushions and eustachian tube. And also examine the neck. Examination of the neck, I think you know examination like for various lymph nodes and all. Ear disease may suggest the pathology. So like the ear disease also may suggest the pathology, something discharging from the eustachian tube into the nasopharynx may also be seen when you do a post rhinoscopy. This thing. So this is what is Cottle test. I've already described. Detect the deviation of the right region of the nasal valve region. So I think I have described it already. Particular nasal valve region obstruction and determine chain to use this kind of this thing. And this is how the nasal tip elevation examination, you'll be seeing that what is that nasal valve skin region. Then you are examining with the tongue dipser, ask the patient to breathe out so that mist formation will be there. If mist formation is more on one side, less on one side, that means obstruction is there on the lesser mist forming side. So this is how that this thing. Not only this, sometimes not only what is that this kind of test, we'll put some material also in the nose to probe test airway resistance and occasionally sense of smell. So probe test, some probes will be there. We can put in the nasal cavity to this thing to determine the deviation of the nose. Airway resistant, occasionally sense of smell also can be seen by the complaint by the patient. Examination of the nose is incomplete without looking into the mouth and pharynx. Of course, ENT means all should be examined. When there is a nose disease, obviously you can have some amount of disease in the pharynx and the ear, as the nose is being called as the bandmaster of the ENT. So airway resistance occasionally, when there is a airway resistance, the sense of smell also being reduced. That is the takeaway point. So now comes to that of the investigations, various investigations. I think I needed to tell something more elaborate. I think we'll go for endoscopy now. In that endoscopy, we can. So investigations, classical investigations. Nowadays, we are talking about endoscopy as an investigation. Unfortunately, it is not. Endoscopy is also nowadays considered as a preliminary examination in OPD. Unfortunately, in our setups, in our government ENT hospital setup, we don't have the OPD endoscopes, but in our clinics, we have a OPD endoscopes and we do it with endoscopic examination. So investigations, they are hematological investigation, microbiological endoscopic, functional, radiological, histopathological, and allergy tests. Various types of these investigations are there. I think the hematological routine, HTT, HBTC, DCS, BDC, DBD, all these things. Absolute replacement count is very much related to that of the our nose pathological system is concerned, because everyone suffers from some sort of allergic rhinosinusitis or allergic rhinitis. So the absolute eosinophil count rises. RBS, blood urea, serum creatinine, liver function test, VDRL, PPI, VDRL, and all that midline granulomatous diseases. So we can, these liver function tests are very important in epistaxis and all. Blood serology for fungus, yeah, of course, naturally. The IgE levels. IgE levels are very, very important to specify the estimation of allergic load, or specific IgE is also to be determined for the specific allergen tests. Yeah, microbiological nasal swabs for culture and sensitivity. Now we are seeing, you must be seeing, nasopharynx is the colonization region for most of the pathogenic organisms. So the corona also, the ideal way to confirm the corona, to test to get a good swab is it's nasopharyngeal swab. It's never a oral swab, unfortunately, because of the workload we are doing in the oral swabs. But the ideal swab to be taken is nasopharyngeal swabs itself only. Aspiration of the sinus fluid, like sinus fluid from the this thing for culture sensitivity, microbiome. What is that? Maxillary sinus, especially, we can aspirate. And proof puncture to know that whether there is any disease and all that, and sputum for AFB, especially when there is a midline granulomatous disease and tuberculosis and all. Endoscopy, yes, coming to the point, endoscopy is very, very important. I think we can discuss and talk about at least 1 hour on this, but I don't know, because of the slide which is spent on all, so much of nonsense. Time is going every time like this, only every. So endoscopic examination, there are various types of endoscopes are present: diagnostic nasal endoscopy and nasofaryngoscopy. So nasal endoscopy itself is called, we can see the nasal endoscopy, nasopharynx and all, put a rigid and flexible, both are rigid and flexible. So we are doing only rigid most of the times for this thing. There are different advantages of doing a rigid this thing rather than I think rhinomanometry is the examination of doing a pressure estimation of doing active and passive rhinomanometry. Passive rhinomanometry is like madam is written. Active rhinometry, passive rhinometry is like assessing the pressure of the nose in a normal individual by closing one side of the nose and pushing this thing is active rhinomanometry. And we could do, there is another entity called acoustic rhinomanometry. Acoustic rhinomanometry is one manometry where there is no much of this thing. You take that particular probe and keep in the nasal cavity at various places and assess take an average pressure. I think there is a lot to tell these things. Unfortunately, time's up. Radiological investigations: plain, lateral, anterior, posterior views, Waters view, suboccipital view, Cordwell view, occipitofrontal views, and occipitomental views. So Cordwell or occipitomental view, frontal views for the maxillary sinus and frontal sinus. Waters view for the all sinuses, especially for the sphenoid sinus. A review, Reese view, CTPNS, MRI, and all. ఏ నువ్వు 2 minutes చెప్తున్నారు కానీ మనకి సెట్ చేయడం మాత్రం క్లాస్ అవ్వట్లేదు.
అదే మీ క్లాస్
ఒకసారి చెప్పండి అమ్మా, నెక్స్ట్ క్లాస్ మా ప్రొఫెసర్ పంపుతాను. ఇట్స్ నాన్ సెన్స్ గా ఉంది అసలు, ఏమి చెప్పకుండా అలా రావటం వెళ్ళిపోవటం. ఓకే, ఒక 5 నిమిషాలు టైం తీసుకుంటాను మేడం. I would like to discuss more about this regarding radiology. Endoscopy is direct rigid nasal endoscopy. But endoscopy is the visualization of nasal cavity by means of a distal illumination. These endoscopes are 0 degree, 30 degree, 40 degree endoscopes, which you can visualize the nose completely. With a camera monitor, you can see the picture also on the TV screen or something like a good screen, where everything is visible in a magnified, illuminated way, so that the what is that? The diagnosis can be more accurate. So you have to take a 0-degree endoscope or 30-degree endoscope, where we would like to have two passes. Initially, third pass is also there. One is through the floor of the nasal cavity. You go through the between the inferior turbinate and septum, go through the up to the and post end of the nasal cavity. You could visualize the eustachian cushions, fossa of the Rosenmuller, and posterior wall of the nasopharynx, and post end of the septum and all. And at the same time, when you go into the second pass, it is between the middle turbinate and lateral wall of the nose. The middle turbinate is gently pushed medially so that you can get into the middle meatus. When you get into the middle meatus, you can see the unsnit process and bulla and openings of the all maxillary sinus and all frontal sinus and ethmoidal sinus and all. But when you go from the later on, the third pass is when you push the middle turbinate bit medially, bit laterally, and you go between the middle turbinate and septum, so that you can visualize that of the sphenoid opening, sphenoid os. So like that, you can see the all sinuses openings. Almost all the anterior group of sinuses opens into the middle meatus, post group of sinus opens into the sphenoid traces. So when you see the openings of this sinuses, which reflects the pathology of that particular sinus, by close observation of that due to with an endoscope, I think we can come to a conclusion that which sinus is being diseased in which way and what is that particular disease. Is it just inflammation or chronic inflammation or allergic inflammation, or it is fungus etiology or some malignant etiology or some mucocele or something, benign tumor or malignant tumor or malignant mass, even posterior like bind biopsies and all, like posterior wall of the nasopharynx, and like eustachian tube and fossa Rosenmuller. We used to struggle very hard when we are doing post-radiation days to take the biopsies from the fossa Rosenmuller for confirming the nasopharyngeal malignancies, which is now very easy with the endoscope and all. So the visualization is greatly improved with the aid of endoscopes and all. So that's what I would like to convey. I think these things can be should be seen in practical only. Uh, Radiological investigations, these are the particular radiological investigations. To the X-ray is to assess the preliminary disease, whereas the CTPNS is to know the anatomical configuration of anatomical configuration of the whole sinuses from anterior to posterior in a multi-directional way, that is axial, coronal, sagittal, and the spiral CT gives you a good information. The bone will be in a hyperdense this thing, whereas the sinuses will be looked at seen as a hyperdense in black region. Actually, on the CTPNS, the mucosa is not seen. The mucosal lining is not seen. If the mucosal lining is seen on the CTPNS with a thickened lining on the inside of the nasal sinus cavities, that itself indicates the patient itself is suffering from chronic this thing, sinusitis. When the MRI is for the more of soft tissue lesions, MRI is for the more of the soft tissue lesions. Now comes to that of the allergy tests and all. I don't think I can complete. Ophthalmology is already came out. I'm sorry. I'll come back again. Thank you.
We went there with problems.
ఏమన్నా మనం ఏం చేయగలం 10 నిమిషాలు